From the heartland of the United States and one of the leading children's medical centers in the world, welcome to the Children's Mercy Kansas City Pediatric Bioethics webinar series. We invite international leaders to discuss critical and controversial issues in bioethics. Now, from the Bioethics Conference Center on the Adele Hall campus, here's Dr. John Lantos.
Got a bunch of announcements before I introduce our speaker and topic for today. First of all, a stunning lineup of upcoming webinars. On Thursday, October 19th, Jody Halpern, Chris Feutner, and Wynn Morrison will be talking about shared decision-making in pediatrics. They'll be here for a conference we're doing the day before, and there are still about 2 or 3 slots left in that conference. So if anybody wants to register, go online right now and get one of those last 2 or 3 spots. Other people will be at that conference, including Dan Brudney, Kathy Patterson, and Vanessa Madrigal, as well as myself. We have a bunch of brown bag workshops for those of you who are here in town. Coming up, Leslie Ann McNulty is going to be talking about the myth of the good mother on September 26th. On October 24th, Beth Sonneville talking about transforming views of gender and transition. All those are right here at Children's Mercy. We encourage people to apply for our certificate program, our nurse leadership program, or our full-time 1-year on-site fellowship here. Information about all those is on our website. And we hope to see everybody at ASBH. ASBH is here in Kansas City, October 19th to 22nd. There are about a dozen Bioethics Center faculty and alumni presenting at that meeting, and we're having a reception Friday evening from 5 to 7 at Milano, a little Italian restaurant right across from the conference hotel. We'd love to see former students, faculty, and anybody who just wants to learn more about the program. Stop by and we'll buy you a beer. We're also going to be going on the road. Brian Carter and I will be in Kuala Lumpur and Singapore at the end of November 23rd to 28th. So if you happen to be in Malaysia or Singapore and want to talk pediatric bioethics, come by and see those conferences as well. With that as introduction, we'll have more exciting news about other upcoming events with each of the future webinars. It's a great pleasure to introduce today's speaker, my friend and former colleague from the University of Chicago, Harold Pollack, who is the Helen Ross Professor at the School of the Social Service Administration, affiliate professor in the Division of Biologic Sciences, co-director of the University of Chicago Crime Lab, which does randomized controlled trials on methods to try to reduce crime rates in Chicago. He's published widely both in peer-reviewed literature and also in outlets like the Washington Post, Nation, the New York Times, the New Republic, and even had an essay that was included in the Best American Medical Writing Collection in 2009. If you want to learn more about health policy or Medicaid, Google Harold Pollack and Medicaid or health policy, and you'll find dozens of really well-written articles. He's going to talk to us today about the future of Medicaid program.
Thank you. Thank you so much for having me. It's a delightful experience. My title is called The Future of Medicaid. I probably should call it Medicaid as the Future of Bipartisan Health Policy, which is sort of the strangest title for the people that follow American health policy you could possibly imagine. They're, let's see, and I'll just, I should tell you that I have a PhD from Harvard and a degree from electrical engineering. I cannot operate the slide clicker. Such is life.
Next slide.
Next slide, please. So this is what this is it's a mural from the last time I was here in Kansas City, where I went to Ronald McDonald House, and I just had a delightful time with the people there and got a sense of how important this hospital is. I met patients, families from Colorado, from Southwest Kansas, people with really profound challenges that we're getting world-class care in a very compassionate way, and that always stayed with me. Next slide. For some reason, I was very taken with the kitchen at the Ronald McDonald House. I recommend that anyone go over there and steal from their refrigerator when you can. Next, please. So I also could have titled this, What Happened? Now, what happened? That would not be Hillary Clinton's memoir, but it would be the way that the Affordable Care Act repeal and replace effort in some ways really solidified the public consensus around Medicaid and around universal coverage in a really interesting way and in a surprisingly bipartisan way. And I think it's actually worth noting as we think about where our healthcare system is going. Now, how we're going to move ahead, I have no idea. But I think it's worth noting that that we've had, in an ironic way, the failure of a major legislative effort actually had a huge impact on expressing what Americans believe about healthcare. Now I know that some folks who are listening today and watching today are international folks who are not as familiar with the U.S. healthcare system. So I'm going to start with some slides just to tell you sort of a little bit of the description of what Medicaid, how many people are on Medicaid, some of the basic facts about Medicaid, and then I'll launch into a 9-hour exegesis of my random thoughts about it. And one of the points, though, that I really want to end up with is there is a consensus in America for universal coverage that was not as apparent a year ago as it is now, and that everyone in America is entitled to have health insurance that actually works if they get really sick. And how we do that, who pays for that, what it looks like, no consensus on a lot of those points. But it's a surprising turn of events in the past year, or it's revealing a surprising latent public consensus that maybe was there before, but we didn't know it. Now, how are Americans insured? I should just start with just some basic facts. This is as of 2015. If we looked at it today, that employer bar would be down a smidgen, and that Medicaid bar would be up a smidgen, but the basic story would be the same. That roughly half of Americans get their health care through an employer, their own employer, their spouse's employer, a parent's employer. That we are the only wealthy democracy where there's such a strong link between employment and health coverage. I think across the political spectrum, Democratic and Republican health policy experts would love to unwind that. It's not clear anybody else in America wants to unwind that, but that's a fundamental fact. There's a relatively small number of people, less than 10% of the American population, get their health coverage in the individual or the small group insurance market, all the people that are on the Affordable Care Act marketplaces, for example. That's actually a surprisingly small group of people who get individual coverage. About 20% of Americans now get their health care through Medicaid, and that'll be the focus of a lot of my talk, which is about, you'll see more than 70 million Americans, and I'll say more about that. About 55 million Americans get their health care through Medicare. Now, broadly speaking, Medicaid provides services to people who are eligible on the basis of low income or on the basis of a significant disability. Medicare is predominantly people over age 65, but also includes people under the age of 65 who might qualify because they become disabled later in life if they've been connected to the workforce. There's other public insurance I won't talk too much about, like the Veterans Administration, people with military health care, things like that. And then slightly less than 10% of the U.S. population is uninsured. We have about 27 million Americans who are uninsured. That's come down by about 20 million with the passage of the Affordable Care Act, but we still have work to go. And of those 27 million, I should mention, about 8 are people who are unauthorized residents of the United States. So about 8 million of that, so a little bit less than a third of the uninsured are undocumented people. They're So if we look across the country, one of the interesting things is that the country, there's a lot of geographic variation in everything that I just talked about. So if you say, what is the proportion of people who have employer-based coverage? It's pretty high in Kansas and Missouri, and it's pretty low in Florida. Why do you think it's low in Florida? A lot of retirees in Florida. There's all of the bar graph that I showed you. If I did it by state, it would actually look different quite a bit across the states. So if we look at who has individual coverage, there's some states where there's quite a bit of it, although in none of the states is more than, say, 10% of the population relying on the individual health insurance market for all the discussion about it. And some states have very, very low proportions. If we look at Medicaid, it's really striking how some states have now more than a quarter of the population are on Medicaid. And one of the really interesting issues that people are now thinking about for the first time is a state like West Virginia, Arkansas, Mississippi, a very large percentage of the state is going to be on public insurance their entire life. And they're going to be on CHIP, which is Children's Health Insurance Program, or they're going to be on Medicaid. They'll eventually be on Medicare. One of the really interesting things that we have not talked about as a society yet is how do we actually use public insurance more effectively as a tool for population health? And we've spent, I would say, the entire ACA fight over the past 7 years has been, how do we cover people? How do we pay for who's covered? The question of how do we actually use Medicaid to more effectively make people healthy is something that we really have not grappled with that question. And I'll mention there's a lively debate about whether health insurance makes you healthier. And in some ways, I think that's a stupid debate because for one thing, it's entirely conducted among people who actually have good health insurance and are talking about other people. And there's lots of reasons why everyone should have health insurance. But it's a very valid point to say, we spend a ton of money. And are we doing it the most effective way we could? Now, if in Arkansas we know that a quarter of the population are going to be on Medicaid their entire lives, shouldn't Medicaid be asking questions like, hey, what kind of food are you serving in the high school cafeteria? When people develop type 2 diabetes, that's us. We're going to be the people who are trying to help that person. So what are you doing around the social determinants? That's a conversation that we're not having because we're still in the knife fight about universal coverage. But I think that critics of Medicaid make a very good point that it could be much more effective in promoting people's health than it actually is. I think that I'm very proud that we've expanded Medicaid in a lot of ways, but it could be a much more powerful tool. And there is something ironic about the way we are so proud of supporting a young person's physical health needs, but it really doesn't bother us to send that person back to their housing project or to a lousy school or to be in an environment where none of their other needs are met, but they can come to Children's Mercy and get excellent health care, and which I'm happy about, but what about these other issues? Percentage on Medicare, of course, also varies across the country, partly because of age differences. It's really striking, but if you think of the 2016 election map, it's astonishing how much older people drove the result. And you look at this map, if I superimposed it with the Electoral College results, it would look, the really dark colors here would match up pretty closely with President Trump's winning coalition. And the percentage uninsured also varies a lot geographically. In fact, if I weighted this, I have a slide that I sometimes show, but it looks so much like a bad acid trip, I'm a little reluctant for human subjects reasons to show, where I weight this by population. What you see is so many of the uninsured are in the southeastern United States. And that's particularly true if we focus on U.S. citizens. The southeastern United States is really where the large number of people are left uninsured because of the Medicaid expansion that was rejected by those states. About 3 million of the uninsured in the southeastern United States are people who would be on Medicaid right now if these states had taken up the Affordable Care Act's Medicaid expansion. Okay? little bit just about the enrollments in Medicaid. I'll get past this. I realize for some of you this is incredible review, but I know that some people watching this may be helpful. Medicaid enrollment has exploded. But what's interesting about it is the spending really has not exploded that much, because most of the people that we're adding, so the red bar is enrollment, and actually that's on the axis, on the left axis here. I've done the two-axis trick. And the right axis is the total expenditures on the program, which have gone up, but they haven't gone up actually in an explosive way, despite the fact that there are well over twice as many people as were on the program 20 years ago. And the reason is we're adding a lot of young and healthy people.
Is that millions on the left? So
Yeah,
70
sorry, these
million.
are units of millions of people on the left and billions of dollars on the right. There. Healthcare is the only arena where you talk about $100 billion like it's nothing. Most of the people that have been added under the Affordable Care Act to Medicaid, which has really done the majority of the heavy lifting in reducing uninsured, are relatively inexpensive people. So the costs have actually not been that explosive. If you look at Medicaid spending per enrollee, it's actually been flat. And part of the reason it's been flat is because we're adding people that are pretty cheap. Okay. So so that's just some basic facts about Medicaid. Now let me mention why I'm bullish about bipartisanship in Medicaid, and then we'll open things up. So as I mentioned, Medicaid is now providing health care for 74 million Americans. And it's interesting, I gave a talk in May, somewhat similar to this one, to a group of health political scientists. It was at the moment when it looked like the Affordable Care Act was going to be overturned. The House had just passed, in a sort of surprising way, an effort to repeal the Affordable Care Act after an initial failure, and it looked like what people call Obamacare from 2010 was going to be overturned. And my talk was titled, Medicaid is the Future of Bipartisan Health Policy. And my audience said, what have you been smoking? And it's really striking the way things ultimately unfolded. As I'll mention in a minute, Republican governors turned out to play a critical role in that, largely due to Medicaid in turning back the repeal effort. I should say that I don't come to this in a totally unbiased way. I have so many ways I touch Medicaid, probably too many. One is I've researched Medicaid. After this is over, we'll email out. I wrote an article in a journal called Democracy, some policy issues that I talk about in more depth than I can do in the next 3 hours right now. But that was just a fright to see if you were paying attention. I'm also an advocate in the process. I was a worker bee working in various Medicaid advocacy capacities. I'm happy to talk about that. And I'm a Medicaid consumer. My brother-in-law lives with an intellectual disability, and he's been a Medicaid recipient. And since about 2004, we've been taking care of him, and we're very grateful for the Medicaid benefits that we receive. One of the striking things about Medicaid that is interesting is that we would never put him in a private health insurance product ever. There's a lot about Medicaid that is, we wish were better, because what's Medicaid's fundamental problem? Anybody have a sense of that? If I can turn the tables on you. Yeah.
It's expensive.
That's its fundamental problem from the point of view of the federal budget, and it is expensive. What's its fundamental problem from the point of view of people at the human who are
Finding willing providers.
Finding willing providers. Medicaid does not pay enough, and that is a real problem. I'm sure it's a real problem for this hospital. From the patient's perspective, though, there's a simplicity to Medicaid that is striking. That is the one problem that you really have, is finding people who will take it. But you don't have weird co-payments and deductibles to worry about. There's a simplicity to it. And it's really designed for people who have no money, with a pretty comprehensive benefit package. And Sarah Cliff, a reporter for Vox, was going around Kentucky and places where a lot of low-income people were voting for President Trump, even though they were beneficiaries of the Affordable Care Act. And she was asking people, why are you voting for candidate Trump, who has pledged to overturn all this stuff? And one of the surprising things that she heard was, I am working really hard. I'm a working poor person, and I have crummy health insurance. And my cousin, who's a total screw-up, doesn't work at all. He has much better insurance than I do. He gets Medicaid, and I don't think that's fair. And that was a really striking change. You know, that the human experience of being on Medicaid was better than the private insurance a lot of people get. I should say I also run randomized trials, as John mentioned, involving criminal offenders and people leaving the jail in Chicago. And we have an intervention where we've set up trailers just off the grounds of the Cook County Jail for people leaving. And David Meltzer, my colleague, is the principal investigator, and I'm sort of the Joe Biden of that effort. And the idea is that when people leave the jail, just when they're at high risk of sort of slipping through the cracks and having a really bad outcome, we provide them a place to be, case management, and it's we think it's a promising intervention. That's made possible because everyone leaving the jail essentially is insured through Medicaid. 10 years ago, we could not have done this intervention because the services that we wanted to provide, we would have had no way to be reimbursed for the addiction services, the mental health services, the things that people need. And one of the striking things about that, when the ACA was passed, many of us realized that one of the most important aspects of the Medicaid expansion was the impact on people with addiction and mental health issues and people going through the criminal justice system. The Affordable Care Act said if you're a low-income person and you don't have insurance, and you don't qualify for health insurance through any public program, you're not a mom, you're not a vet, you're not disabled in a recognized way for federal programs, you can get Medicaid. And if you think about that for a little bit, you realize, the criminal justice population could be a big chunk of those people. And wow, that's politically scary for people that were supporting expanding Medicaid. Are we going to have, many of you may remember that in the 1988 election, there was a man named Willie Horton, who was a man who was furloughed in Massachusetts and committed a horrible crime and became a big political liability for the Massachusetts governor who was running for president. Were there going to be Willie Hortons that were Medicaid recipients who committed an atrocity? Here's what's interesting. No one's tried to do that. Republicans around the country are totally aware that the criminal justice population and the addiction population, mental health population is a big part of the Medicaid expansion. Republican politicians have not tried to use that as a way of attacking the Affordable Care Act, attacking President Obama. And the reason is that Republican officials around the country realize, hey, we got to take care of these people. And how are we going to do that? And they're using the Medicaid expansion to do that in a serious way. And I think that's just a really interesting development. A lot of Democrats that I talk to more Democrats than Republicans, just given my life as a University of Chicago academic. A lot of us think of the Republican Party, and we don't really think of the governing Republican Party around the country, of officials who run stuff and are responsible for rural hospitals and state prisons and parole and probation systems, people that are not bomb throwers. And my research team, I can talk about this in the Q&A, we spent a lot of time talking to Republican officials around the country. Most states in the United States have Republican governors. And people are very, very serious about the public health opportunities that Medicaid provides them and the resources that it provides them with. And the one thing that we hear the most often talked about in these conversations is the opioid epidemic, and how so many of these officials are saying we gotta have something that helps us deal with this crisis. A lot of states actually expanded Medicaid because of the opioid crisis, and their state legislatures talked about it quite explicitly. New Hampshire is a good example, where people were really on the fence. Do we want to? It was politically contentious. Do we want to expand Medicaid? We have to because we have people dropping dead who need addiction treatment. And when we talk to officials and we say, well, how are you thinking about all the debate in Washington? We were interviewing people during the time that it was unclear what was going to happen to the ACA. The most common response we got from officials was, our governor has told us, just keep doing the work. Don't worry about the politics of this aspect. And it's very interesting. Another interesting connection one hears about a lot is violence. There's this debate, does Medicaid make people healthy? In Chicago and Detroit, before we had Medicaid expansion, we had people walking around the city with missing pieces of skull because they couldn't find a provider. They were uninsured, who get shot in big city America, uninsured people. People could not find a surgeon to finish up the work if they had a head wound, or they were wearing colostomy bags because they couldn't get the surgeries that they needed because they were gunshot wound victims with an abdominal wound. We don't see that. We don't see that anymore. I don't know what they do in Atlanta, Houston, but in Chicago and Detroit, that's made an incredible difference. On the ground, in many states in America, not in every state, but in many states, what you don't see the same polarization around Medicaid that you see in Washington. That you get if you watched MSNBC and Fox News, you would get a sense of the health policy debate that doesn't capture the on the ground reality. And let me make a political science point, and then I think I'm going to stop and open up. I have a million comments I could make, but I want to open things up as much as I can.
Let me remind people online, we're going to start doing discussion probably in about 5 minutes. If you have a question or a comment, you have a little chat box down in the lower right-hand corner of your screen. Just type in a question or comment, and we will read them out, and Professor Pollack will give you the answer.
So I'll give you a contrast about what's happening politically. I was in Washington, and I was in some meetings with Democratic and Republican congressmen asking, what are the prospects for bipartisan health policy? And everyone kind of understood that the prospects at the moment were low, but what's over the next hill? And the Republicans that I talked to, they were smart and nice people. Health was not their passion. They wanted to repeal Obamacare, but the repealing Obama part was the part that was really their passion. The Obamacare part was a kind of, that was sort of a different thing. And they were actually looking for a way. A lot of them were not real happy about the way this debate was going, because they were like, I'm trying to be a responsible legislator. I'm in this sort of impossible political situation where our parties we kind of have to do something that deals with the centerpiece partisan achievement of the other party now that we're in charge. When I talk to Republicans in the states, people and Republican governors in places like Ohio and Nevada are the kinds of places that come to mind. There's a tactile discussion that was not happening in Washington. So if you compared the materials that Speaker Ryan's office was putting out with the materials that were being put out by the governors were writing about the legislation from the perspective of people that were going to have to live with this for the next 10 years. Like, if you're going to do Medicaid block grants, here, we don't really want you to do that, but if you do that, here's the formula we want you to use because we're worried about the following 6 things. It's written by people that had a granular engagement with it. That was not the way, the Republican politicians in Washington that I talked to, they were genuinely surprised when the Congressional Budget Office came out with, very damaging assessments, which I think Republicans around the country were like, well, yeah, of course that's what it's going to say. Now, what's interesting is the same Republicans that were defending Medicaid did not care at all about defending the Affordable Care Act state marketplaces, and didn't know very much about what was happening in their state. If we said, what's happening with addiction and Medicaid, somebody in the state government would say, here, I'm going to give you a 12-page memo that actually we just wrote about what's happening with covering methadone and matching up treatment guidelines with what our Medicaid program covers. Say, what's happening on your state health insurance exchange for people with addiction issues? And there's parity requirements. You get blank stares. And the reason is transactional politicians know that they own Medicaid, they can use it for their own purposes, and they're going to be accountable for it. Their view of the state marketplaces is there's one politician in America who owns those, and he's not president anymore. And so when I think about the future of American health care, I think public insurance is going to play a much wider role. And one reason why is that there's a huge fight to expand health coverage, but once that fight is made, politicians actually own that what happens. So a lot of Republicans opposed Medicaid expansion, but once it happened, they own it, and they want to use it effectively for policy goals that they share. And I think that over the past year, my sense of how likely is it that someday 45-year-old people will be able to buy Medicare or Medicaid coverage dramatically higher than it, I've dramatically increased my assessment that that's where our healthcare system is going. Because not only do people not like private insurance, but it turns out that politicians aren't willing to do much to defend the private insurance system when it comes under attack. And whereas they will defend Medicaid and Medicare and feel that they are the defenders of that. So just yesterday, Senator Sanders came out with his single payer plan. So now everything else is moderate now. If you want to propose that anyone should be able to buy Medicaid in Missouri, that's now makes you a moderate within the Democratic Party. Things are moving, and I think Medicaid will play a huge role in that. And I think and both Democrats and Republicans, we have to think about where do they want this to go. A lot of Democrats hate Medicaid, would rather see Medicare for all, didn't want Republican governors to play a big role. Well, it turns out that when Democratic policies came under attack, it was awfully nice to have all these Republican governors there to whisper to their senators saying, please don't do this. And whereas if we had a Medicare for all system, President Trump and Tom Price would be running it right now. I'm not sure Democrats would be overjoyed with that. Let me stop there and engage in some dialogue.
Sure, some very provocative comments. Let me start with a question relevant to us here in Kansas City. Neither Kansas nor Missouri decided to expand Medicaid to the extent that your vision sees the states that did expand Medicaid now owning it and supporting it. And that's why it's going to expand. What's going to happen to the states in the Southeast or Midwest who were pretty adamantly against Medicaid expansion?
Well, it's funny. A lot of those states, people were quietly talking about they would expand if Hillary Clinton had won the 2016 election. A lot of Republican state legislators around the country, not particularly, Kansas and Missouri, I think not particularly, but although Kansas is its own special case. Actually, every state is its own special case. I shouldn't say. Here in Illinois, we should not be talking about any other state in any. We're the only state with a driving while governor profiling problem. There, 5 of our last 10 governors have been incarcerated. I think most of these states will expand Medicaid. I think they will do that in a Republican way. I think both Democrats and Republicans kind of need a dignified path to get there. But if Mike Pence could expand Medicaid in Indiana, people can find a way to do that. And there's so much money on the table that I think it will happen. And it won't happen in a way that Democrats particularly like. I think that you'll have to pay co-pays to go to the emergency department. There may be a work requirement. It won't look like a Massachusetts Medicaid program, but it'll be an advance. And I just think there's too much money at stake. And now that the repeal effort seems to have failed, I just think that there will be more voices at the state level saying, well, we've been leaving on the table huge amounts of money, and once it's expanded, then you can never pull. It's irreversible. So you just need enough of a window of opportunity to do it.
So you think we'll see many different varieties, and it will be easier to get federal waivers against Medicaid requirements so that states will have a lot more freedom to design their programs as they want them to be?
I think that the Trump administration will let a state do pretty much anything it wants to do. And Democrats will be really upset about some of those things. And my response to that is, Republicans win a lot of elections, and elections kind of matter. And there'll be a Republican policy vision. I think that is actually, that's the outcome, that's what federalism is. And I'll object. I won't be happy with some of the specifics, but I think the overall pattern is good.
Go ahead, Mara. You have a mic. I'll take questions from our live audience, but again, if you're online and you have a comment or a question, just type it into that little chat box and we will read it out.
Hi. So is the difference between this Medicaid for all and a single payer system just more control for the states, or?
So there's a variety of proposals on the table right now to expand coverage. One is everyone should be able to get Medicare. And that has the advantage that Medicare has a golden brand name among Americans. It turns out if you ask Trump voters, very, very large numbers say, yeah, people should be able to get Medicare. It turns out Trump voters are not economic conservatives in the way that one might think. They're, now, some states like Nevada have said, well, we actually want to do that through Medicaid. And at the state level, that's a much, you control Medicaid. You can't do a single payer system as a state.
Or a Medicare for.
You couldn't do Medicare for all as a state because federal government runs it. There are differences. The benefit package for Medicaid is in some ways more appropriate for people and more compatible with other requirements that Medicare is. So one of the questions that I think we're in for a period of floundering and creative experiments where different states are trying lots of different things, where they're just going to let more people buy public insurance. And some models will emerge from that the federal government will try to seize on. And I don't think we quite know what those are yet. I would suspect that if the Democrats win in 2020, that people over the age of 50 will have some way to buy Medicare coverage at paying a premium that depends on their income. The question of one of the big differences between Medicaid and Medicare, first of all, how much will the states have to pay? And secondly, how do we think about people with disabilities for whom Medicaid is just much more fundamental?
Thank you.
Other questions?
Good.
Yeah, so I'm trying to think about what a transition would look like from having private insurance companies mediating the relationship between payers or being the payers, and then a transition to more people on Medicaid, everybody on Medicaid. And so some hospital, I think including ours, lose money on every Medicaid patient who walks through the door, and then we have to recoup that from people with private insurance. And so I'm curious, what are your thoughts about what happens if Medicaid becomes very popular and we expand it to all the states, but then the federal government, for cost reasons, or state governments, for whatever reason, instead of paying market-driven rates that allow hospitals like ours to stay afloat, pay us, 72 cents on the dollar, for example?
Well, I think that's going to be the knife fight that's coming because both parties have, in their own way, collaborated to underpay healthcare providers in Medicaid. Republican health policy experts always raise this as a way of criticizing Medicaid, but have exhibited zero interest in actually increasing those rates when they've had the chance to do that, because that would require raising taxes, which is a theologically impossible thing to do. But Democrats have done the same, and some of the states that underpay the most egregiously are very liberal blue states. And it's because, as a politician, you get a lot of credit from your constituents if you say, we've covered more kids, we've made our program more generous. The fact that we pay for that by underpaying the provider is under the hood, and people aren't as aware of that. I think the more people who get onto Medicaid, the more the political coalition to try to change that increases. And right now, Medicaid has the problem that its major constituents are poor people and healthcare providers who serve poor people. And as you start to see more middle class people on Medicaid in various ways, they can pressure for those access problems to be addressed. And I think that that is going to be a very, very serious fight. Senator Sanders, his single payer plan implies a pretty disciplined approach to provider payment. And whether we as a society are really ready to deal with the consequences of that is a very serious question. You know, if you look at almost every other wealthy democracy provides better health care than the United States does, insures everybody, and pays usually a third less than we do. But the way they do it is they pay providers a lot less. And they squeeze providers and use the government's market power. And, you know, you go to rural Kansas, rural Missouri, you think, what is that going to do to the hospitals there? We haven't had to discuss that as a society. So I don't know how that's going to play out, but I think you're putting your finger on a fundamental issue.
I mean, one of the big differences between Medicare for all, as I understand it, and single payer is that many people who have Medicare have supplemental insurance. In Canada, where they have more traditional single payer, for a long time, I think this has just started to change, it was illegal to sell private insurance to cover anything that the single payer plan would cover. So that single payer plan was egalitarian, covered everybody, and could negotiate rates because providers had to take it. If Medicare for all in the Sanders bill means the government provides you half of the insurance you need, and if you have enough money, you buy the other half on the private market, will that be better? Will it function like single payer?
Well, but every country around the world that has universal coverage does it differently, and does it in a way that's consistent with its own history and the path that it got there for. You know, Canada created a single payer system because starting in the provinces, and you know, Saskatchewan had what was essentially the model for what became the Canadian system. England comes out of the trauma of the Second World War and uses that moment of national crisis and solidarity to create a national health service. Most single-payer systems have a role for for-profit providers. Most have some way that rich people can buy things that are not available to other people. There's a Medigap, the equivalent of Medigap, exists in a lot of countries. Mm-hmm. Now, the Sanders plan actually would make it illegal to provide coverage that's redundant with what's in Medicare, but they would still be, you could still have a Medigap type plan. Insurance companies will have a role in whatever we do. First of all, they have expertise. They know how to build a website, for example, that doesn't crash on the first step. You know, they know how to administer claims. They know how to do a lot of the blocking and tackling of healthcare finance, and they will be contractors. They will not. The insurance industry will not disappear, and whatever we do, they're. And I think that, I mean, already Medicaid, for example, around the country, there's managed care plans. There's the line between private insurance coverage and Medicaid is actually pretty blurry in people's lives in a lot of states. So, you know, I have the Anthem Purple plan, and that's actually a Medicaid managed care plan, but you know, the Anthem, you know, Mauve plan is not a Medicaid plan, but it looks pretty similar. And there's going to be all sorts of hybrid models out there. Medicare Advantage is a hybrid model. I think what they all do, by the way, in other countries is the government very often provides the pricing list. So you can provide other benefits that the state benefit doesn't provide, but this is how much we pay for a doctor visit. Mm-hmm. And that's where you save the money, is government using its market power to just tell doctors and hospitals, this is how much we pay. And sometimes that would be good for Medicaid because it would bring Medicaid up and it would bring private reimbursement down. You could imagine that could actually be good for Medicaid access. Mm-hmm.
So I'm going to ask a question that has to do with other governments contrasted to the United States. Mm-hmm. My first observation is none of the examples that have been held up as what other democracies and industrialized nations do serve 300 million people in nearly as diverse a population as the United States. So I have to admit that I tire of hearing how Finland and Germany and France and the UK and Canada operate, because they're truly not comparable. Secondly, in most of those social democracies, there is a reduced outlay on the part of collegiates to receive an education. In all of the Scandinavian countries, university is free. In many of the countries that we're talking about in contrasting healthcare systems, the government, as much as it supports healthcare, also supports collegiate education. No such comparable model exists in the United States. So you have people graduating from college with $100,000+ debt, going to medical school and graduating with now $300,000 or $400,000 debt, and entering a system in which they try to basically pay over their career, their loans down, and could not, in my mind, I can't see how that would be accomplished in a single payer system where the government dictates the reimbursement for physician fees and services. In other words, you can't have one without the other. How could we link the goals and aspirations of a healthcare system that's affordable to an education system that's affordable?
That's a good question. I mean, there's a lot in you asked a couple of questions. The comments about sort of comparing us to other countries, it is true we are large. The contrasts are more similar than they used to be in some of the countries that you mentioned. If you walk around Western Europe, they're increasingly diverse societies that have crime rates very similar to the United States, for example. Not they don't have guns, so the homicide rate is a lot lower in most. But actually, if you look at interpersonal violence, very similar to the United States. They have antagonisms between ethnic groups and regions, and well, you know, as Brexit being exemplifying that. And we will see actually whether their social democracies are under new kinds of pressures as they have to deal with that. The way medical care is organized is often more similar than Americans would expect. If you look at like the number of MRIs that people get, things like that, you know, I think a lot of Americans believe we cost so much more because we do so much more intensive medical care. And if you actually look at lengths of hospital stays and intensity of imaging, things like that, that's you know, we're not an outlier in the way that you might think. It's the prices that are so much higher. Your question of how do we manage the reality that physicians, it's very expensive for physicians to be trained in the United States, and we expect physicians to bear more of that cost than other countries might expect. I think that's a valid point. It's a valid point directly that we have to somehow balance that, and you know, we do that to some. You know, Medicare does worry about that, and there are Medicare payments for medical education and so on. It also affects the sociology of the medical profession profoundly. And one of the things, when I started getting involved in the healthcare politics, it really struck me how I did not realize when I started how the internal politics of the medical profession is so, A, how educational debt is so fundamental, and B, how different pieces of the profession think about it so differently. You know, if I would go in and talk about the ACA with primary care physicians, I'd have such a totally different conversation from talking to radiologists or talking to people in their specialties that required more training. And part of it was that people had different business models, and part of it was that people had different levels of debt. That you know, you talking to someone who could have $400,000 or $500,000 worth of debt, you're just going to have a different conversation with that person. It's not just doctors, it's also nurses. Most of the labor costs in the United States health system are not doctors. Nurses, the entire supply side of the medical economy gets higher prices in the US than in other countries. And if you say why the public option failed, there was an effort in 2009 and 10 to allow people to buy into Medicaid or Medicare, to do some sort of a public option as part of the Affordable Care Act, and it failed. And one of the interesting subterranean political factors there was a ton of the people who supported everything else about the Affordable Care Act quietly opposed the public option, because you had rural hospitals, for example, that were saying, you know, I can't have Medicare across the table for my 62-year-old patients. Now, I'm not one of those greedy people that is against universal coverage. I'm one of the good guys, you know, in terms of the politics of and I'm just telling you, I don't like this piece of it. You know, I'm the biggest employer in this rural county. I got to get my full reimbursement from Blue Cross Blue Shield on my near retirees to keep my doors open. It gets to your question as well. And we have to, I think that it's going to be a really tough political fight.
Tough transition period.
Yeah, the transition period is going to be, but I think whatever happens in the transition period is decades. I think the Sanders bill, the transition period is officially 4 years to get to a single payer. That is clearly not, that's not on planet Earth as something that will actually happen. And then you're identifying one reason why you cannot tell all the physicians who have various kinds of business models. By the way, as of next year, it's totally blown up. So all those kinds of issues are real. Long-winded answer.
A couple of questions online.
First online question says, are you familiar with PAMA implementation and how that will affect Medicaid dollars for lab reimbursement?
You know, I just don't have the expertise to give a good answer to that question, but I will email that questioner with a more thoughtful answer.
The next question says, having had to pay for more than my copay this morning, even at my doctor's office, do you see a growing trend of regular insurance also underpaying providers in the future? And if so, how would you see this impacting public coverage? I do. Well, I think that private insurance is becoming delegitimated, and that was the everyday experience of the sort that you describe. Millions of people are having it, and you know the pharmaceutical companies, big hospitals, doctors, everybody is economically interested in the healthcare space. I mean, every time you're talking about trillions of dollars, you know, everybody is in there wanting to get their cut. And people know, for example, that hospitals want to get paid a lot. They know that pharmaceutical companies want to get paid a lot. And people often think in a particular case, they don't like the way a hospital behaved. They don't like the way a pharmaceutical company behaved. But everybody kind of understands why the hospital exists. You know, like we think that Pfizer should exist, even if we think they should charge less for X drug. And when you get to insurance companies and you say, why does an insurance company exist? A lot of people start scratching their head. And they say, well, and one thing is they could be providing insurance to the healthy people and keeping those and making sure the healthy people don't pay for the sick people. Well, most Americans are like, well, we don't believe in that anymore. We don't believe in that. So insurance companies that's not part of their business model. We could say they're managing the care for people. And then Americans say, well, I don't really know that I trust private insurers to be care managers, which I think is a real problem because insurance companies have genuine expertise and a lot to offer. In fact, in the single payer systems, they have private companies that do a lot of entrepreneurial activity to manage advanced cancers, things like that. The public is very distrustful of that. And people have these everyday experiences that are just very grating of the sort that you describe. And I think that the insurance industry has to figure out a way to maintain public confidence if it has a long-term model to really survive, because the whole idea that we, for example, improve the disciplined provision of cost-effective care through co-payments and deductibles, the evidence base for that is, you know, actually reasonably questionable. And so they're really in a bind. And I actually feel the insurers are, people blame the insurers for so many things that are really not their problem, but it's because people don't really understand the legitimate role that insurers should play. That was a very verbose answer to your question, but that's my...
I mean, it would be one thing if I had any idea what my copay or deductible was going to be for any particular service. I mean, then it seems I might be able to make a rational decision about whether to do that. But I'm not sure what the experience of the person who wrote this question is, but my experience when I go to a doctor these days is I have no idea whether I'm going to have to pay nothing, $10, or $432.
It's interesting, there's a large employer that actually provided advanced decision supports, had a very high-tech workforce, and provided all sorts of computer supports to try to help their employees manage. They gave people basically health savings accounts and a lot of decision supports to try to use that account effectively. And people really struggled, even though they were affluent, highly educated people. If you actually looked at the way patients behaved, they did not optimally respond to the incentives the way that people had hoped that they would. I would love to see more people who are affluent have catastrophic policies, just to see if people, like something like hip replacement, you would think that, like probably if you have some sort of a problem that just comes up, it's not worth your time to figure out all the complicated, to go do an OJ trial to figure out what your deductible is going to be. Probably if you needed a hip replacement, you really could do some comparison shopping. And it would be, there's some areas where I think it would be nice to see the market operate. I don't want to oversell it. There's probably some areas where there really is some value where people could suss that out. But if for a lot of routine medical care, people just don't want to bother.
Yeah.
Other questions?
Yeah, one more.
My question relates to just the structure of how our healthcare system payers are structured. So,
Medicare and Medicaid commercial. And it seems like what's happening is the money that's available for patients and the money that's available to administer is, there isn't a lot of discussion about the administration costs of our different payers. And I think that's one of the advantages with Medicare is their administration cost is the lowest. So I think my question is the ethics of bringing that into the equation and more of a awareness of how much are companies spending administratively.
So administrative costs, it's certainly true the United States has a lot of administrative costs and complexity. A lot of that administrative cost and complexity, by the way, is a function of our dysfunctional health politics and regulation, and we would have it under, which would also be the system creating an alternative single payer system, for example. So that we would a lot of that bureaucracy we create by in ways that's in our DNA to do. It's true, Medicare has very low administrative costs. They probably should have more careful administration than they do. Some of the administration is a complete waste of time, and it's people trying to avoid paying bills and getting someone else to pay. And some of it is care coordination and things that are kind of real. And you want to distinguish that. You also have to balance that. Medicare, because there's one of the critiques of a single payer that is accurate is that you would have to have a really large movement onto the federal tax system or the state tax system, if a lot of it was through Medicaid. And the tax system has its own administrative costs that would be part of that. And a reasonable single payer system, if you shifted everything onto a single payer, you would basically have to raise an amount of money that's equivalent to doubling the federal income tax to pay for that. And that's assuming that you'd have some pretty stringent cost control. There would be a lot of administrative costs that would come with that in some way, in incentive issues with high taxes. So I am somewhat pessimistic. I think some Democrats make the argument that we will have huge savings by reducing administrative costs. And I sort of think that's a little bit like they were going to get people to go to emergency rooms less kind of argument, that when you actually start to get into it, you realize, this isn't really Like there's issues here, but that's not, it's going to be hard for us to extract savings that we think are there. So what worries me about the administration is much more, is it lowering the quality of the care we provide and burdening patients and providers with, and making it unpleasant to be a doctor and to be a patient because you have to deal with all this junk, more than huge amounts of money that we're going to somehow figure out a way to get out.
Thank you very much. We need to stop. Let me just remind people, in October, we have two great webinars coming up. Thursday, October 19th, Jody Halpern, Chris Feutner, and Wynn Morrison, all talking about shared decision-making in pediatrics as a sort of panel discussion. And then at the end of October, October 30th, Dom Wilkinson, a neonatologist and philosopher, is coming all the way from Oxford University to tell us about his thoughts on the Charlie Gard case. So you don't want to miss those. There's still a few spots in the Shared Decision-Making Day-Long Conference on the 18th of October. Get to our website now to register for that. And join me in thanking Harold Pollack for telling us about Medicaid.